Good afternoon, everyone. I'm Elliott, Maine, and I'm going to be doing the next session on a topic that we don't talk about very often, which is maintaining quality improvement efforts. I am the director of the California Maternal Quality Care Collaborative, a professor of OBGYN at Stanford, but I also chair the Maternal Mortality Review Committee for the state of California. So the theme of today is to get rid of backtracking. Backtracking is a common issue that we have to deal with for everything that we do, and we're going to talk about some strategies for that. I have no disclosure, no conflicts, and we're going to talk about maternal mortality, maternal morbidity as one of the prime issues of the day. First of all, in context, it has been one of the great successes of the last century. If you go back to 1900, we were at 800 per 100,000. The rate is per 100,000, so that is a big denominator. That's the rate that you see in sub-Saharan Africa. The big peak that you see around 1920 is, of course, the secondary peak there is, of course, due to the last great pandemic. And I'm afraid to say we're already seeing a blip for 2020 with the rise in maternal deaths due to our current pandemic from COVID-19. As you see, by the late 1970s, we went down to a very low single-digit rate of maternal mortality per 100,000. And then in the 1900s and early 2000, we started to see a rise here, both in California and the US. The US is in red in this slide, and California is in blue, rising from single digits up to 15 to 16. And this is when we started looking at it in more detail in California in our Maternal Mortality Review Committee, which was started in 2007 for sessions. And we looked at it a little bit differently because we wanted to be particularly focused on what were the quality improvement opportunities that we could learn from each review of each tragic maternal death. And we turned those into toolkits. We turned those into then quality collaboratives. And over these last years, and then that's been associated with a significant fall in maternal mortality in California. There are other things that are going on at the same time besides quality improvement efforts. We've seen a change and an improvement in payment throughout this period, but this is clearly on the right track. So we started Maternal Mortality Review Committee forming in 2006, met in 2007, multidisciplinary team from all parts of California, and we went on. We chose the folks so they could play a key role in the quality improvement collaboratives that followed. Importantly, when you review maternal deaths, it's looking at deaths that occurred within a year after a birth, which means that it takes about 2 years to identify all the deaths and then actually review them. So we're now into, actually, since I made this slide a while ago, we're now into 2018, 2019 deaths, and we're focusing on specific causes. Maternal mortality and severe maternal morbidity have different distributions of causes depending on whether you're looking at a death or a major complication. As noted, mortality in California is about 10 per 100,000 or less, which is 1 to 2 per 10,000 births. So that's, again, why maternal mortality is not a useful parameter to look at from a hospital basis, or even from a county basis, unless you're Los Angeles with 130-odd thousand births. So we've often looked toward ICU admissions, which occur 10 times more commonly than a death, 1 to 2 per 1,000, or severe maternal morbidity, the CDC definition, which is, again, 10 times higher, 1 to 2% or 1 to 2 per 100. Now, when you look at the causes of maternal mortality, the leading causes are thromboembolism, infection, hemorrhage, preeclampsia, and cardiac disease being the most common of them. all the others vary year to year. They're about 10 to 15% of the causes. Cardiac disease is 25 to 30%. The remaining is largely driven by underlying medical conditions. But when you move to ICU admissions, now hemorrhage and preeclampsia or hypertensive disorders are the leading cause of maternal of severe morbidity or complications leading to ICU admission. But when you look at the SMM by the CDC definition, it is dominated by hemorrhage and preeclampsia. When we looked at measures of preventability, and you can measure preventability a couple of different ways. Big series from the CDC working in North Carolina desk just called it Preventable. Judgment yes or no by committee. We thought it was hard in our committee in California to measure preventability because you're not there, you're looking at retrospective records. And it's always hard to say whether something was truly preventable. We chose to define it as good or strong chance to alter the outcome. And the leading preventable causes by our definition were hemorrhage and preeclampsia, which were also the leading causes in CDC's review in North Carolina deaths. The UK has a little different approach, substandard care that had a major contribution. And again, hemorrhage and preeclampsia were at the top of their list, with infection running very closely. When we looked at the underlying quality improvement opportunities represented by hemorrhage and preeclampsia, we found things that were very common, very recurring among deaths, commonalities here. And these included missed triggers and risk factors, so people not paying attention to vital signs, including pain or altered mental status, underutilization of key medications or treatments for hypertension, for example, or for hemorrhage, difficulties getting physician to the bedside, location of care issues. We found that the PACU was a particularly concerning spot, as well as the emergency department. The University of Illinois regional, looking at their regional perinatal networks, did a similar study and found the same commonalities: failure to identify high-risk status and incomplete or appropriate management. What was stunning about hypertension and preeclampsia is one or more of these issues were present in almost all the cases. Not all of these were preventable, but they all had cofactors that were opportunities to improve the care. So when we started our process about in 2010, 2012, in terms of our journey for quality improvement, we had this as a summary. Hemorrhage and preeclampsia were the most common preventable causes of maternal mortality. They had far and away the most common cause of severe maternal morbidity, accounting for 75%. And they had high rates of provider quality improvement opportunities. These were events that were acute, happened in the hospital by and large, and were largely preventable. So we summarized essentially a lot of the findings with the 3 deadly Ds. This is your memory aid here: denial, delay, and dismissal. Dismissal, not listening to patients actively, not paying attention to what they said. Dismissing the complaint is a critical part. So over the next 10 years, we've run a whole series of collaboratives in California. You remember the very first one, the reduction of early elective delivery, while we were doing the initial maternal mortality reviews, but then we've run pilot collaboratives on hemorrhage and preeclampsia, and then very large collaboratives of 90 hospitals, 130 hospitals. As you recall, we finished our supporting vaginal birth reducing primary C-section collaboratives at 3 cohorts, 100 hospitals. And recently a mother-baby substance use, that was also a large number. And now we're working on a birth equity pilot we're going to discuss at the end briefly. So what's key for any quality improvement project is having good data. And this is one of the strengths of CMQCC, is having a data center that takes data directly from state sources that are already existing. So this is not making or asking the hospital to collect any additional information. But we get birth certificates here on the right every month for every birth in California from from the prior month. And we also get discharge diagnosis files on both the mother and the baby. Again, from every hospital, almost every hospital in California, about 95%, on a monthly basis. By 45 to 60 days, we can link them all together and feed them back to the hospitals for a whole range of quality improvement projects. The types of bundles that we've been implementing are illustrated here. The national safety bundles for early elective delivery, hemorrhage, and preeclampsia. Those have been the mainstay. But as you realize now we're dealing with a whole lot more bundles. CMQCC has published bundles on cardiac, on cesarean, as we mentioned, breastfeeding, venous thromboembolism, implicit bias, depression, delayed core. These are all things that are out there. We just put out one on sepsis, and there's more on the way. And this is a problem. The problem is all are needed, all are of value, but each new one creates competition for attention. So now we're getting into where we want to talk for the rest of this session is how do you do project maintenance? Project maintenance or sustainability is, continue to ask the question of, are we doing what we need to do? Maintenance is often overlooked with the assumption that once we do a collaborative, once you do a project, and it's done, is it, once it's tackled, is it done? It is done. And so you move on to the next. And maintenance is not nearly as exciting as new projects, but it's actually just as important. And we're going to talk about some internal approaches, some external approaches, and then the combination of the two. So what do I mean by internal approaches? So the goal here is to, of course, establish a new process of care as part of the unit work or daily workflow. So that's how you sustain it in the long term. Is once you can get it into the daily work of a unit, then you don't have to think about it too much. So examples of that are putting it into your EHR, your electronic medical record, your Pyxis or other workflow tools. And the examples of this would be order sets, screening tools, best practice alerts or reminders, things that go into the workflow. One thing that's often overlooked is orientation for new hires or travel nurses. Folks that aren't used to the protocols and the workflow of your unit, you have to be able to orient them with your hemorrhage and hypertension protocols or all your older projects that you've done. And you need periodic re-education for all staff, both physicians and nurses, because things, as we jam more and more things into our brain, older stuff tends to fade away. One of the things I particularly like to do on units is to have recurrent celebrations. In life, you could never celebrate enough. So you want to celebrate continuing success on hemorrhage or on hypertension and the like, and keep them alive is the point. So let's look at a case study here. The very first project I mentioned at the beginning that we did in CMQC, one of the first national initiatives in obstetrics, was the elimination of early elective deliveries, i.e. elective deliveries before 39 weeks of gestation. Why has that been a long-term success? It's gone down by 90% across the country, in California as well. Much of the residual is because there are always coding issues that aren't covered by the measure early elective delivery. But it's been a long-term and sustained success. So how did that come about? Well, as I said, it became a national initiative, so everyone was talking about it. It became a national quality measure. It's on the inpatient quality report for CMS, which is a Medicare quality measure, which is interesting that it got into Medicare since, but that was fortuitous because Medicare does pay a lot of dollars to hospitals for quality incentives. So even though it doesn't pay for births to any degree, having it in the Medicare measure set meant that hospitals had to pay attention to it. And there were dollars. So that meant it became a focus of quality improvement efforts by hospitals' quality departments. So examples of external approaches would be with the goal of reinforcing new processes of care as part of the daily workflow again. So you want to link it to a quality measure. Public reported is the best. You want to link it to payment where that's possible or appropriate. There can be target incentives, minimum target for inclusion in network. Those are kind of harsh, but there's a lot of attention paid to pay for reporting and pay for meeting at least national targets. The last one is also an important one, which is linking to accreditation, and particularly the Joint Commission, which comes to make visits on us every 3 years. And this is where a lot of attention for our maternal safety bundles is now in play. The Joint Commission last year released standards for perinatal safety to be used for accreditation. They put this off to the by a year to avoid the struggles that we're having with COVID. But now they're starting to review cases this year using the new standards for perinatal care, which have focused, and we're going to talk about this in detail, on hemorrhage and hypertension. Also, Blue Distinction, which is the national quality plan for Blue Shield and Blue Cross, have decided that maternal safety bundle adoption, particularly hemorrhage and hypertension, are things that they want to include in their best practice hospitals. In terms of national metrics or quality measures that are under development in this area, CMS or Medicaid nationally is looking at bundle adoption as a measure. Have you adopted the hemorrhage and hypertension bundles? A related measure, which I mentioned earlier, severe maternal morbidity, is driven by hemorrhage and hypertension. That's becoming a national performance measure as well, both for the Joint Commission and CMS, again, Medicaid. That will happen with risk adjustment. That's a process they're working on right now. It's probably it's a year and a half away, but Joint Commission has already called it PCO7. So hang in there for that one. But let's look at what we mean by sustainability and how we can help that on your unit. So we hope that every unit in the country now has a hemorrhage cart, and we hope it's being used. We don't want this to happen on your unit, that you develop something and just put it in the corner and it slowly atrophies from disuse. So what we've done at CMQCC to help support these activities are a combined what we call internal and external approach. And we're harnessing the data center to help this process of sustainability. For those of you who live in the data center, this is the landing page. And now we have pieces on here, titles on here for Patient Safety Watch, which is about hemorrhage and preeclampsia, and we'll drill into that. As well as measures for recent collaboratives, such as opioids shown here, or C-section shown elsewhere. And you'll see at the top, and we'll come to this at the end on this slide, there's a birth equity area on the data center. So I mentioned earlier that the new standards for perinatal safety came out of the Joint Commission. That was going to be rolled out effective 2020, got put off to 2021. And it's basically taken the National Safety Bundle, which is in our toolkit from ACOG and AIM, and they have turned them into standards. Now, they're worded a little bit differently because the Joint Commission uses standard language as opposed to quality improvement language. But for example, their first element for this is hemorrhage. First element is to use an evidence-based tool for determining maternal hemorrhage risk. So you're supposed to do a risk assessment on admission and after delivery at a minimum. Number two is that you have evidence-based procedures for a stage-based management of hemorrhage, i.e. do you have a good solid protocol that has these kind of elements. And it goes on through a total of 7 elements that have 16 parts to them, because some of these are multi-part. Like the top one is, do you have a hemorrhage supply kit or cart? Do you have education, and do you running drills? And do you review hemorrhage cases in detail? And you provide education when possible to the family, particularly pre-op or at the time of discharge. So we turned the data center into a way of monitoring and helping hospitals complete all these different elements. Together with one by in the Joint Commission standard, describing its rationale, an example action that staff should be able to do on a Joint Commission visit, and with documentation resources that you can refer to. You can check these off on the right-hand side. It's not in place, or provide the date. When you provide you can do that for one after the other. Here's another standard with resources. You provide the dates and they go away and shows completed, and you go on to the next one. So it's a way of showing that all the things that you've done in preparation for a Joint Commission visit and preparing your staff for it. Likewise, there's a set of standards for hypertension now from the Joint Commission that are based on the bundles. And likewise, we have data center pieces that are exactly there for it and allow you to follow the progress in meeting the Joint Commission standards. So we really feel strongly that you should have 2 different streams of thinking when you come down to OBQI. So this is our vision, that you have one stream of thinking about implementation of new QI projects, and another one for maintenance. So you have basically either two people or 2 distinct efforts going on in your QI, one for implementation and one for maintenance of completed projects. And we like to say that a QI project is never done. It's never finished. It's just at a different stage of life, okay? It's moved on from a active implementation to a different stage, this time for implementation. You need staff time for both, and you need reports on both, because otherwise they fade from view. So just examples again, you integrate whatever you can into your electronic health record. It's part of the orientation for new hires and travel nurses. It's part of periodic education for all your staff, and it's on your communications board for labor and delivery. That would include local measures, updates, new studies on the subject, and we were offering to do periodic news updates on these measures from CMQCC. So that's all good, but here's the big question. Are we improving care for all women? This is not really the case in America, not really the case in California either. This is maternal mortality over the last decade up to 2014 from US data. And you can show that Black women represented by the purple have the worst outcomes by far, up to 50 per 100,000, whereas non-Hispanic white in the green line are down at about 18 to 20. So that's pushing a 3 to 4 times higher over this time period. The only group that's really equally worse than the Black is American Indian women in the light blue that's very jagged because they have relatively small numbers and therefore fluctuate year to year, because as you remember, this is a rate per 100,000 births. Okay. So let's look at California. As you saw in the last slide on the left, the US has been going up over these time periods. When you look at race, you often put it into 3-year rolling averages because the numbers do get small. And you can see in the US, it worsened in all races except for Asian Pacific Islanders in this. They stayed flat, but white and Hispanic and Black women all rose. California, all races did fall, but the Black-white ratio remained approximately the same, 3 to 4 times higher in Black women. They fell by almost half, but that Black-white ratio remained at about 4 times higher. Okay. So now let's ask the basic question: is why do Black women do so much worse? On severe maternal morbidity, they're about twice the rate, and here on mortality, they're 4 times the rate. You know, a couple of years ago, I would have answered the same way as most doctors and nurses answer this question today, which is that Black women have more obesity, more hypertension, more diabetes, more social disadvantages. Let's look a little bit more closely at this. What if we looked at Black-white disparity in severe maternal morbidity only among college graduates? Okay. And adjusted for age, BMI, and other clinical and demographic risk factors. What we see is that you still have Black-white disparity among college graduates. It's actually more than 2 times higher than whites, and overall, it's about 1.9 or 2 times. So actually, it's worse in college graduates than in younger. But even more distressing is when you compare severe maternal morbidity in Black women who have college degrees versus white women who didn't finish high school. Black women do significantly worse. College-educated Black women do significantly worse than white women without even a high school diploma. There is no way escaping that there is many other key factors that play here. Normally, precisely how we take care of women, i.e. racism, is at play. We take care of Black women differently than white women. This kind of data shows that we don't treat everyone the same, even though that is a common sentiment that I or everyone would have. And that when we look around, this is present in most of our hospitals. And so folks with our data center are not able to say that it doesn't happen here. So principle number 1 right now is there's no quality without equity. But we treat everyone the same, but is treating everyone the same the right answer? And this is really the difference between equality, giving everybody the same. In this case, it's everyone the same bicycle, no matter if you're handicapped, if you're tall, if you're a woman, if you're a child. But equity is giving people the resources they need based on what they bring to the table. So you have a different type of bicycle for a handicapped person, for a really big person, a woman, or a child. We've done a lot of work this last 2 years in the data center, bringing you birth equity reports. And this is where we're going to talk about for the last part of our session here today. We have it on our home page. It's We focus on two key outcomes that are quality measures nationally and important measures locally, which are the NTSV C-section rate and the severe maternal morbidity rate. So these are now stratified by race and ethnicity for the major categories in California. Non-Hispanic Black, non-Hispanic White. We actually break Hispanic women into born in the US and born foreign born, as well as Asian PI, though we are probably going to break up Asian PI into smaller categories going forward. We have other measures besides those. Those are the two we're highlighting, but all of the measures now in the data center are stratified by race and ethnicity. And we have a birth equity PDF report that can be shared with your around the unit or with your management team or with your board for that matter. Hospitals have used it for all of those. Pretty simple to identify the birth equity PDF. You just push on that and you can pick how the race you want to highlight. So there are a lot of hospitals in California in which there are very low rates of Black women delivering, and you may choose a different population to look at besides non-Hispanic Black. It could be Hispanic or Asian Pacific Islander, for example. There are three different ways of doing comparisons. We're going to talk about two key measures, as I mentioned, severe maternal morbidity and NTSV C-sections, and three different types of comparisons. And we're going to, let me walk you through each of those to show how they work. So the first comparison is your selected race or ethnicity category compared to all others. So we're not comparing them to white only, but to all other women. So this is an example of NTSV C-section, Black versus all others. And this is a sad state that we see on the average, Black women have a higher rate of NTSV C-section than white women, but not in every hospital. Actually, in California, there's a big range. Averages hide a lot, and there are hospitals that have the same or even a little bit better for Black women than white women. So this question answers or addresses, is there disparity in your hospital outcome between the different groups? The next comparison that's given here is over time. So now you're comparing the baseline period to the most recent 12 months. Here you're given, in this case, your Black rate versus your all other rate in your baseline period, and then comparing it to the most recent time period. And you can see in this hospital, the Black rate fell from 30 to 26%. That's pretty good progress. And the white rate fell from 23 to 22. So it was a narrowing of Black-white differences. So are we improving outcomes in our target community is the question that this is addressing. The third comparison is against others. So here you're comparing your own hospital to a peer acuity, by acuity, i.e. the same NICU level, average rate. So now we're comparing your hospital against all other hospitals with the same nursery level, level 4 nursery or a level 1 or level 2 nurseries. So this shows you, again, over time and how you're doing against other hospitals that are like hospitals. And so this is really important to see how you compare against others, which gives you some insight. Okay. Now, I want to emphasize in the last couple of minutes that improving equity involves working at multiple levels. As you all know, in California, SB 64 is requiring that perinatal providers take implicit bias or in a broader version of equity education. as a state law. So hospitals are gearing up to do that for their nursing staff, and they're encouraging their physicians to do it as well. There's 3 different offerings out there that are all pretty good right now. Diversity Science has come out with 3 modules that are relatively short each. The HHS, Office of Minority Health, has 2 modules, online modules that are quite well received. And March of Dimes also has a set of, so there's a good range of options for our hospitals to choose from. But I want to emphasize that this is a necessary step, but it's not hardly sufficient. You know, we've never been able to change care just by taking a course. You have to be able to reinforce it at many other levels. The other levels that we're working on here in California is rapid cycle data, like what I just went through for the last 3 or 4 slides. We're doing clinical quality improvement, working on areas that have high black-white differences, such as C-section. But what we're learning from doing clinical QI is that you can improve it often for all, but you're not going to close the gap. And to do that, we've really been working hard on developing an equity QI bundle, i.e. a series of actions to take in the hospital to improve and reinforce what you've learned in the implicit bias and equity education. These would be things like active listening, working on diversifying the workforce, upstanding for microaggressions and direct anti-racism activities. So this is a bundle that 4 hospitals in California have been working on developing over the last year, and we hope to have this be able to be spread out in the fall. So stay tuned for that one. Even that's not enough, because you can't just work in the hospital and expect to fully improve health equity. So that involves community engagement and policy changes at the state level, as we're seeing a lot more of maternal deaths occurring in the late postnatal period. That underscores the need for continuing coverage for things like substance abuse, mental health, as well as underlying medical conditions, and the leading cause of maternal death, which is cardiovascular conditions, which occur predominantly in the postpartum period. So we've designed the data center to support you on the Joint Commission standards, which is an important step for sustainability, and the release of the Maternal Health Equity Dashboard, and more things to come in terms of an equity bundle. So I'm going to stop now and look for questions and ask if you've used any of these resources in your effort to preventing backtracking. Thank you, everyone.
Thank you, Dr. Main. This is Valerie Cape at CMQCC, and I'm going to pose a few questions to you that have come in from the attendees. The idea of competition, for projects. Thanks for bringing this up. The question is, as a nurse manager, how do I work with that? How do I prioritize the projects so that they don't compete with each other, even with my department staff and time? It's rather overwhelming. How can I approach that?
Yeah, that's really the theme of the day, is that there are so many different ways we can improve care that your head spins. And I think you have to concentrate on one at a time. We've really discouraged folks in California or nationally to do 2 or 3 projects at once. Of course, we have to multitask, but you want to be able to concentrate on one, but still have data that you're bringing the previous projects up and have it in front of people's minds. So you have one that you're working on and one that you're reminding people about. If you have to do several at a time, it's nice to at least stagger them by several months. But you have to be able to keep supplying some data for the prior ones as you do them, but as much as you can integrate them into your daily workflow, that's really the secret.
So you're saying that those kind of reports and the data, that periodically reporting on those prior efforts will help the sustainability because it
Yeah,
keeps the focus on for people?
yeah, you have one that you're working on and one that and one or two or three that you're sustaining, but you want to have some continuing reports. So you're in the reports that we have in the data center allow you to make certain you're not slipping. So that's the backtracking of the slippage that we're, and if you don't pay attention, it's human nature to backtrack a bit.
Okay, thank you. The next question that has come in is, there are more and more bundles and safety protocols. Can we expect the Joint Commission to enforce them all? And is there no other way to maintain quality?
Well, it is, we have prioritized some based on that earlier slide where I showed you the proportion of severe maternal morbidity is 75% is hemorrhage and hypertension. Infection is actually one that we've identified as a really important one, and expect more work on that coming, maybe not this year, but next. We're working on changing sepsis standards and so forth, substance definitions, and really making that more clear cut for obstetric patients. I don't expect the Joint Commission to be so structured for all the bundles out there. I think you have to do education where you can, and put in best practice alerts and so forth, things that you learn into your workflow as you go through the bundles one by one. But we're getting to the point where we're having to look outside the hospital. Cardiovascular disease is largely going to be addressed through working with emergency departments and internists in postpartum care, because a lot of the deaths are happening months after delivery. So not everything is acute inpatient, but there are things that we can do, discharge education and follow-up, that are going to be important. So that's a different challenge, is how do we reach the doctor's offices and the emergency departments? And there are some national efforts working on that right now.
Does any of the data include home births?
No, home births are less than 1% in California. Obviously, do not C-sections that occur at home births. There are some deaths that have occurred at home, but there's not a structured place of working to improve care in home births. Not all home births have even licensed providers. Some are unattended, and that makes it very confusing. Most of the issues that we're seeing, to be honest, are hospital-based.
Okay. How have the rates of morbidity for groups other than Black women changed for the 3 areas of preeclampsia, infection, and hemorrhage?
So Hispanic women have about a 30% higher rate of morbidity, even though their mortality rate is the same as whites. Their morbidity rate is higher, and it's about 1% higher. One of the biggest contributors to severe maternal morbidity, though, are pre-existing conditions, comorbidities, and that drives a moderate proportion of the Black severe maternal morbidity, but not so much in Hispanic. The Hispanic population tends to be younger and have less pre-existing conditions than many other populations. But they have certainly significant morbidities. It's not particularly higher in one category versus another. Black women have a little bit more hypertensive issues, but Hispanics are about even to whites for hemorrhage, hypertension, or infection.
Okay. Is there any recommendation from other PQCs or other efforts outside of national efforts for sustainability or reducing maternal morbidity that we should be aware of?
So our perinatal quality collaborative, CMQCC, was one of the very first and largest in the country. And we've been working with all the other PQCs. They're now up to over 30 in the country. Most states are being encouraged to start them. They're at varying stages. The most mature ones are in Illinois, Florida, New York, and Ohio. And we work with those on a monthly basis. There's a national network of perinatal quality collaboratives, and of course, there's the National AIM project, the Alliance for Innovation in Maternal Health, that is HRSA funded, but also pulls together all the leaders from all the PQCs on a monthly basis. So we do learn from each other. The lessons we talk about today are sort of a summary of the things that we've learned from others as well as ourselves. We're further along as we've done all the bundles essentially in California, whereas many of the other states are just starting out on them. You know, we did hemorrhage, 6 or 7 years ago, so much so that we've had to redo our toolkits. We should have a new edition of Preeclampsia toolkit coming out this summer. And we should have a new hemorrhage toolkit coming out later in the year, because you have to upgrade them every 3 to 4 years. And there are changes in care for both of those that have happened over the last 4 to 5 years. So stay tuned for those. We'll send notes to everyone as soon as those come out.
We have one last question that's come in. In your opinion, what's the causes for the disparities in severe maternal morbidity in the Black population?
Well, it's a very complex issue because it involves quality of care, it involves comorbidities, and it involves social determinants, but does involve racism, but the causes of maternal mortality, there are multiple causes of maternal mortality, multiple causes of severe maternal morbidity. And for hemorrhage, for example, it's largely quality of care. For cardiac disease, it's a lot more comorbidities and racism. So each of the causes will have a different set of those secondary or contributing factors, if you would. But racism plays a part. But so does comorbidities, so does structure, where you live, the social determinants, or structural racism, as it's also called. And so there's not an easy answer to that, but it means that you have to work on all 4 areas. In the hospital, we have to work on quality of care, and in racism, and in policy, we have to work on community factors. And in long-term healthcare, it's about comorbidities. Thank you.
Great. Thank you, Dr. Main, for that great presentation. We will sign off this session. There will be a short break. The next session for medical legal will start at 2:45. So we'll see you then. Thank you so much, everyone.
Bye-bye.